Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Well, hello, everyone. Today we have a special Gastro Girl podcast episode that we're producing in collaboration with the ACG Patient Care Committee. And we're also joined by two very special guests. They are both members of the American College of Gastroenterology, and they're members of the very important PR committee, the Public Relations Committee of the American College of Gastroenterology, of which Dr. Tauseef Ali is chair, and Dr. Pooja Singhal is his number one colleague on that committee. In fact, they even work together in Oklahoma at SSM Health St. Anthony Hospital. So we are so lucky today to have both of them. And I didn't tell you what the topic is, but we're going to play a little ACG 2021 abstract ping pong. So what does that mean exactly? Well, we just got finished with the American College of Gastroenterology's annual scientific meeting, which was held at the end of October. And this meeting is so exciting every year because this is where all the great science, all the great clinical research, all the learnings and hard work that our member gastroenterologists and friends work on so that it advances patient care. So today we're going to hear about some of these abstract highlights, and we're going to, have a little banter between Dr. Singhal and Dr. Ali. So without further ado, welcome, doctors. We're so happy and thrilled to have you here today.
Okay, great. Thank you for having both of us tonight. It's going to be fun. And I think without further ado, we should just go ahead and jump and start playing ping pong.
Yeah, let's go.
So Dr. Singhal, you go ahead, please.
Sure. Good afternoon, and thank you, Jacqueline and the team of Gastro Girl for inviting me, and Dr. Ali. Like Jacqueline said, we had incredible entries of cutting edge research and studies and review of studies this year for American College of Gastroenterology. And I would like to share some of my top interesting studies out of the incredible stuff that was presented. And I chose these studies based on relevance and importance to public, and how these studies are going to be, some of them are going to be landmark trials that is hopefully going to move the treatments forward. So having said that, my first one that I would like to talk about is the study by Dr. Mohammed Bilal and Dr. Asma Shaukat, focusing on the impact of the new screening colorectal cancer guideline on adenoma detection rate. It is titled Impact of Addition of 45 to 49-year-olds to Screening Colonoscopy and Overall Adenoma Detection Rates using GI Quick Registry. So let's kind of dissect that a little bit. I said a lot of things there. Basically, in 2021, most societies changed their recommendations for screening for colon cancer to age 45 years old, as opposed to 50 years old. And this was a very, very important change. This is irrespective of race or sex. So universally, the recommendation now is age 45. To screen for colon cancer. And as you may know, colon cancer is the second leading cause of death in the United States from cancer-related deaths. So this is extremely, extremely important. And as gastroenterologists, of course, we're very passionate and focused on prevention of colorectal cancer. Having said that, colonoscopy is a very, very important tool, screening tool to detect cancer and precancerous polyps. So we know that colonoscopy can reduce the risk of death from colorectal cancer by detecting tumors at earlier, more treatable stage through removal of precancerous adenomas. So then what does adenoma detection rate mean? Adenoma detection rate refers to basically the proportion of screening colonoscopies performed by a physician that detect at least one histologically confirmed colorectal adenoma or adenocarcinoma.
So basically that means it can detect a cancerous polyp.
That's correct. So the rate
Great.
is, for example, if I'm scoping 100 patients and my adenoma detection rate is 30%, that means that I have diagnosed 30 people with adenomas or adenocarcinoma. And that's important because the benchmark right now for men should be 30% for any endoscopist, and for women, it's 20%. So it's a quality indicator. It's a very important quality indicator as an endoscopist. So that gives us an average of 25%. So that's where we want to be, or higher as endoscopists, that we are detecting enough adenoma in general population.
So with your important study that you pointed out, what do patients really need to know about this study, and why is it important to them? And I know you mentioned an earlier age of screening. So can you really explain why patients should pay attention to this study?
Yes, exactly. So this study just very briefly focused on the impact of changing this guideline. So what they did was they went to GI Quick. GI Quick is a benchmark registry, and it's actually in collaboration of American College of Gastroenterology and American Society of Gastrointestinal Endoscopists. And what they did is they created this registry, and lots and lots of endoscopists throughout the nation report, and we track the adenoma detection rate to come up with good quality benchmark and track it. So number one, this study talks about how the age 45 to 49 impacted us. So they retrieved data from GI Quick, and what they found out that mean ADR in ages 45 to 49 was 28.86%, as compared to 32.26% for ages 50 to 54. So the difference between adenoma detection rate in a younger age group was not as much different than from 50 to 54. But overall, if you compare the adenoma detection rate in ages 45 to 49, which was 28.86%, to ages 50 to 75 years old, their adenoma detection rate was 36.8%. And this is important because as endoscopists, when we are looking at quality measures, when our patients are asking us, hey, what's your adenoma detection rate? Because I want to know that I'm in safe hands and I'm getting scoped and the adenomas are not going to be missed. This information is important because now with the change in screening guideline, that adenoma detection rate for endoscopists may be lower depending on if you're screening more people between age 45 to 50.
Well, that's what like makes me go, wow. Imagine if you weren't screening those patients at the younger age. So that if you had a very low level, you may question, well, why do I have to get my colonoscopy at 45? This really shows that there is no great difference, and that those guidelines being changed were absolutely the right thing to do, because you're detecting them earlier at 45 rather than waiting to 50 or 55 when people finally roll around and get their colonoscopy, right? So this is a great study. Thank you for bringing it to our attention. Is there anything else that patients should know, or any questions that they, how do they ask their doctor if they're about to get a colonoscopy? And it's a good thing to know adenoma detection rate. You want a doctor who has a high one, right? And that should be around 30%.
Absolutely. My advice, yeah, exactly. It should be 25% mean, 20% in women and 30% in men. So average is about 25%. You absolutely hit it on the nail. And the second thing I would always advocate patients to ask their physicians is, what's their complication rate? And that's always a good one to ask, or any kind of complications that they should be aware about, because each individual has their own risks. So the physician should take the time to tell them what their risks are.
Oh, thank you so much. This is great. Okay. Now we're ready to, ping it on over to Dr. Ali, who's going to talk about one of his most noteworthy abstracts.
Okay, great, Jackie. As you know, many of you may know that my interest is in inflammatory bowel disease. So all my picks today will be related to IBD, what I learned at ACG 2021, in Vegas. It was a wonderful meeting. We met with each other after a long break, so because of the pandemic. So I thought my first pick would be related to COVID. And one of the interesting article that came across, it was an oral presentation from University of North Carolina group. And it was about antibody response to the COVID vaccine in patients who are on immunosuppressive therapy and have inflammatory bowel disease. A very interesting article or research that they are doing over there about this. And just to recall, there were some publications earlier this year. One was a study from UK showing that patients who got one dose of COVID vaccine, they didn't mount a good response to in terms of antibodies when they were on infliximab. So the response to the first dose of vaccine was not very good. And then all the trials that happened during the development of COVID vaccine, they excluded patients with immunosuppression. So it was kind of like a question that we get asked all the time from our patients that, hey, do I need to stop my medications? Do I need to stop my infliximab or my other immunosuppressive medications, TNF or anti-TNF drugs or non-anti-TNF drugs? So this presentation really helped me understand more about this, and I'm going to do a little bit of deep diving, and then I'll come back and tell you what I learned from this and what is the take-home message for me. So this was a study, a very large study that was done through Prevent COVID, which was a prospective observational study of IBD patients who are receiving COVID vaccine. So it included all in the United States patients who are receiving either Pfizer vaccine, Moderna vaccine, or J&J vaccine. So they did survey of these patients. These patients had an option of getting their blood tested for antibodies 8 weeks after the completion of the vaccine course, meaning they got both series. So they got their dose 1, and then they also got their second dose. And any antibody that was more than 1 was considered to be positive, like they have developed antibodies to it. So all these patients underwent, they were included in this study. They all underwent this testing, and there were about 700 plus patients in this study. And majority of them were females, and about half and half. Half got the Moderna, half got the Pfizer vaccine. Majority of the patient race was white.
And they all had IBD, correct?
Yes, they all had IBD, and they were all on some kind of immunosuppression. So interestingly, what they discovered that patients who were on anti-TNF, non-anti-TNF, such as ustekinumab or vedolizumab, they got antibodies about 99%. So despite taking immunosuppression medication, the detectable antibody rate was 99%. A little bit numerically low rate in patients who were on combination therapy, meaning they were receiving more than one immunosuppressive therapy, such as they may be on infliximab, and they may be in addition, they may be getting enoxaparin. And even then, the rate of antibody was 86%, which I thought was very good, very remarkable. The only thing that this research showed that patients who are on steroids had a little bit lower rate, but still good. It was about 85% or 86% compared to the patients who are not receiving anti-TNF. In them, the rate was about 96%.
So basically what you're saying is patients with IBD who were on some kind of immunosuppressant therapy, who got the vaccination, it still was effective for them. It was effective prevention against COVID, despite the fact that they were taking these drugs. Is that correct?
Yes, and I think that's the conclusion of this abstract was that the vast majority of the patients who were on IBD medication got very good antibody response. So the take-home message was that they don't have to stop their medication in order to receive this vaccination. So they should get vaccinated, and very reassuring, they will mount a antibody response that is similar to general population who are not on any immunosuppressive therapy.
So that really eases a lot of their minds. Like if they were worried that because they were on these medications, that they would be scared to go off them and have some kind of flare, they had to weigh, do I get the shot? Do I go off, stay on my drugs and I can't be around anyone. So this is good news for patients.
Yes, absolutely. I think this reassured not only my patients, actually reassured me also, because we were also like, what should we tell our patients? Because we want the best for our patients. So this initial study and the abstract, and we just have to keep in mind, these are all abstracts, not published yet. So there are limitations, like this study didn't look at the T cell response or the other things, but very reassuring, because everyone is asking, can you check my antibodies? Can you make sure I have a response to the vaccine? So this study was very reassuring to me as a physician, to my staff who were receiving all these calls from the patient, like, do I need to stop my medication before I get the vaccine? So this study really helped us ease our conversation with the patient, and also help the patient to understand that no, they need to continue their maintenance medication and they can get the vaccine.
It's fascinating science. I mean, I don't want to get into it now because I think it's too geeky and sciencey, but it would be interesting to know what was happening on a cellular level for those things to be almost okay. I'm not a microbiologist, but it's very interesting to understand what was going on the cellular level, so that it still had all those antibodies and they were protected, yet they were still okay with being on those IBD medications.
Yeah, and one last comment that I will make before we will pong back to Dr.
I love it.
There. So that this is for IBD, and the immunosuppressive drugs that I'm talking about is for IBD. So there are other immunosuppressive drugs that are used in kidney transplant, B cell depletion therapy for cancers. They may have a very different response to antibodies, and but we are talking about patients with IBD who are on IBD immunosuppressive medications.
No, thank you. I just have one quick question. Was there any difference or variation in those results based on what vaccine they had, or it was pretty much across the board?
It was across the board. There was no difference in any type of whether it was Pfizer, Moderna, and there was actually no difference in terms of age also. So younger age versus older age. They actually did that analysis also, and they didn't find any difference.
Well, thank you so much, Dr. Ali. So now we're going to pong it back to Dr. Singhal for another interesting abstract. I can't wait to hear what you pick next.
Thank you. Thank you so much. And that was very interesting, Dr. Ali. So the next one that I picked, I think is going to resonate very well with a lot of our audience, listeners. It's a study about development and validation of a novel scoring system for bloating and distension.
Oh, boy.
I know. And as a female gastroenterologist, Jackie, I have to tell you, this is the number one symptom complaint that I get. This has kind of become an epidemic of its own, the complaint of abdominal bloating. So I was very, very interested to find out what this study from Mayo Clinic, what they had to tell us. And this study comes from Brian E. Lacey and his team.
Oh, yeah. We've had him on talking about those very topics.
Yeah, exactly. He's one of the experts, as you know. So abdominal bloating and distension are very, very prevalent. It's estimated that they're up to anywhere from 16 to 30% prevalent in general population. And it's estimated based on surveys that that number could be 90% in our IBS patients. And by IBS, I mean irritable bowel syndrome patients. And the study, basically, the goal of the study was to design and validate a questionnaire to reliably measure symptoms of bloating and distension that can be then used for clinical and research purposes. And given how prevalent this symptom is, there was a huge need for this type of scoring system because we currently have none.
For patients that may not know, what is a scoring system? What does that do? Does that mean what like if a doctor asks the patient, how bad it is? Like, can you explain what that is real quick?
Absolutely. So there are different types of scoring systems. So there can be a pictograph, like commonly we use Bristol stool scale, and that scale we show patients pictures of poop. Hey, thanks for coming to my office. Here's a picture for you to select from. And that, basically what a scoring system does is helps us physicians understand and relate better with our patients who are suffering. So that giving a number, like giving a number to a pain scale, 0 to 10, 10 being the worst pain you've ever experienced in your life, it really helps us connect and tap into what you're experiencing. So giving a number to the bloating and the symptomatology and how it's affecting your life is extremely important.
I see why you picked this study, because it does help the patient and the provider really understand, instead of saying I'm bloated. Okay, what does that mean?
Exactly. And bloating specifically has such a complex etiology. We can be bloated because we ate the wrong type of foods. We can be bloated because we have increased acidity in the stomach. We can be bloated, of course, because of irritable bowel syndrome, or in females, especially hormonal changes related to menstrual cycles. So it's such a wide spectrum that giving some objective value and scoring system really will be helpful, in my personal opinion. So this study definitely is very exciting to me. So yeah, this group basically did an extensive literature review and surveyed 6 experts to get feedback on what questions to include. They then revised it, went back to Mayo faculty, got their feedback on the questionnaire, revised it again, and they actually took this questionnaire to a patient focus group, got their feedback on the questionnaire, and then finally revised it. And then it was a 45-item questionnaire. And they did a prospective study where they distributed this questionnaire to 41 patients. And most of the patients were Caucasian and females who did, participate in this prospective study. And the questions included anywhere from demographics, what their prior diagnoses were, duration of symptoms. It included symptom related to dietary changes, symptoms related to bowel habits, the severity of symptoms, frequency of symptoms of bloating, unpredictability of symptoms, goals of therapy, and also impact on missed school or work. And one question that I thought was very interesting, it actually included, was the association with menstrual cycle as well.
That's a good one. And so what happens next? So they did this study and they came up with this pain scale, or bloating scale.
Yeah.
And so does it exist now? Can patients and doctors use it, or what comes next?
So, their study is convincing because they were able to reproduce the results. So they gave the questionnaire day 1, and they repeated the questionnaire day 7. And every question, a 95% item response, it was reproducible. And in terms of validating, so what happens next is when we propose a questionnaire, you have to validate. A bigger sample size of population is needed to further adopt this questionnaire. So I'm pretty sure they're working on that. And one of the take-home points that I learned from this, Jackie, was one of the results was 61% of the patients who participated said that the bloating symptoms affect their sleep. And I thought that was very interesting to me, because when patients come to me in clinic, they talk a lot about how it's affecting their daily life, routine, missed work, but the affecting sleep and insomnia was a very interesting thing that I personally took away, and I will be asking my patients more about that. So
that is so important. We did a podcast interview with Dr. Kathy Goldstein, who is at Michigan, and she gave us some like mind-blowing information about sleep. But this study that you're talking about, it really gives hope to patients, because once the scale is in place and utilized in practice, it will better help them get the right care and for the doctors to know, what areas should be addressed. So this is
Absolutely.
great.
Absolutely. I would even relate it to, like, remember pre-pain scale.
Yeah.
Giving something a scoring system or a scale really makes it an isolated and independent symptom and gives it the respect that it needs. And I think it's going to be more recognized. So it's very exciting.
Well, that's so great. I'm so glad you brought that to our attention because it really puts into perspective why these annual scientific meetings are so important, because it lays the groundwork for what's going on already. And by the time it publishes, they're already working on even more advanced research that even goes beyond what we're hearing. So this is great news. So now are we pinging or ponging? I think it's pinging. Pinging, Dr. Ali. Go.
Yeah, no, thank you, Pooja. I think that was wonderful because, it makes me realize, how do I ask questions about bloating to my patient? So this is good. I think this is, as Jackie said, that this is really fascinating. Okay, so now I'm going to ping back to IBD. So the next article that I thought was interesting, I don't know I think there was a take-home message, but it was just an eye-opening for me from the fact that we know that in the United States, the prevalence of IBD has increased. We have about 3 million people in the United States who are suffering from this illness. And with that increasing prevalence, we are also developing a lot of drugs, a lot of new clinical trials are coming. And one thing that we always remind our patients that we need to make sure that a trial fits you. We can generalize a trial for you. This is not a trial for you. This is not the type of patients that were studied in that trial, and it may not be applicable to you. So how to generalize that trial, it's very important, and that's a message for the patient also. You can't just go on internet and find a trial that this was a fascinating trial, good results, and I want this drug now. But we need to make sure that you fit into that trial. This is how the study was done, the patient population. So that brings up a question about, we also have seen that the prevalence is increasing in non-white population. So many Hispanics, many Blacks, we are seeing that the prevalence is increasing in racial minorities. So then the question comes, do they have adequate representation in clinical trials? So this study that was a very interesting study that was done by a group from Albert Einstein, and they did an oral presentation. Again, they did that study keeping in mind that to look at that and see if there is a difference and what is the rate of enrollment in clinical trials among these racial and ethnic minorities, adults in patients with IBD in the United States. So what they did was they went to this clinicaltrials.gov, looked at all these studies that have completed the enrollment, and then look at all these racial and ethnicity parameters. They had 132 eligible trials that they looked at. Very interesting results in the last 2 decades, from 2000 to 2020. What they discovered that in a total population that they studied, 88% were white, only 6% were Black, 3% were Asians, and North American was only 0.3%. Hispanics were 8.3%. So that tells you that there is an underrepresentation of a lot of minority groups in clinical trials. And then can we apply that clinical trial to those groups? That becomes a challenge. And the authors noted the fact that, it's not that they are not willing. These minority population, that there is an unwillingness among them that they don't want to be enrolled. That has not been the case. That has been proven. So I think we need to, the abstract ended there. The authors just concluded that there is an underrepresentation, but it brings up a lot of questions like how we enroll patients, what is our responsibility, what are the barriers that we need to address. So I think all my listeners tonight, if you're suffering from inflammatory bowel disease, if you belong to a racial or ethnicity minority, then step up and help us get into these trials so that we can enroll patients, study the response of these new drugs in these different minorities, and see if this drug will be best for you when we study in clinical trials. So I think this was just an eye-opening for me.
Oh no, this is, it's perfect timing. We had the great fortune of speaking with this amazing young woman, Melody Blackwell, who is the founder and executive director of COCHI. She ran the first IBD Equity Symposium, and we were just talking about this. And I wonder, because of things that I've learned from her and her advocacy work, is it incidence, or is it or they could have had IBD all along, but they didn't know that they had IBD. I mean, her journey, if you listen to our previous podcast, if you listen to how many years it took her to get a proper diagnosis as a Black woman with IBD, it was mind-boggling, because we also interviewed white male patients who may be struggling with IBD for many, many years. They went finally to the doctor because they didn't think they had anything wrong. And they immediately were given a colonoscopy because they had rectal bleeding. And this poor woman was basically hemorrhaging almost, and she never got a colonoscopy till much later. And it was just mind-blowing. So I think that what you presented here is great news. I'm sure Melody and all of the people that she represents in her advocacy work will be so pleased to hear that there is a conscious effort to include minorities in these clinical trials and to expand education and access so that they feel like they identify with the disease that they may not have identified with before. So this is great. You guys are the gastroenterologists. You know much more than I do. I'm just a passionate patient advocate, and I listen to patients so many times, and this is so timely that we're speaking about this abstract right now.
Yeah, and I think that just brings an awareness also. I mean, I'm more aware now. So now back in my practice, back in my clinical trials, I have become conscious of this underrepresentation. So I actually encourage my patients whenever I identify them, if they belong to a minority, and encourage them, like, participate in the trials. And also it gives me food for thought, like what's happening. Is, as you mentioned, is it that the IBD is on rise in them, that we are seeing them and kind of like appreciating this difference, or it was other barriers, access to care and a lot of other factors. So I think this is, as you mentioned, that this was important, an important awareness, both sides, physicians, provider side, as well as among patients.
Yeah. And she has some really great language around, instead of underserved, it's more like they feel overlooked. They haven't been part of the discussion. And she's just a fascinating young woman. And her podcast listeners, listen to our recent podcast about her patient journey as a woman of color with IBD. It speaks to what Dr. Ali is alluding to and the importance of why this abstract is important. So thank you so much. So now we're going to pong Dr. Singhal, who has another. I can't wait. It's like, I never know what you're going to bring up. I kind of know what Dr. Ali is going to bring up, because it's going to be about IBD. So I can't wait to hear what you're bringing up next.
Thank you. And thank you, Dr. Ali, for sharing that very fascinating study. And Jackie, I also want to thank you for doing the work that you're doing, because just regarding that young woman that you have mentioned, you are this, the spokesperson for her. And I think it's so important in 2021 to recognize any barriers, any overlooked community or demographics from both sides, and inviting everybody to the table so we can be stronger together, and we can hope to eradicate diseases that have treatment. Wishful thinking, eradicating IBD is a big goal, but at least get people in remission. So having said that, I would like to talk about my next study, and this one really is very exciting. This is from Dr. Jessica Allegretti from Brigham and Women's
Oh,
Hospital.
she's awesome.
She is incredible. I got to hear her in person present this, and I'm super excited about it. This is about C. difficile infection. And C. difficile infection is one of the most common healthcare associated infections now. It can be very debilitating. It definitely life-threatening, depending on the age and comorbidities of the patient getting this disease. And more importantly, recurrent C. difficile infection has become very, very hard to treat, and has become very common after the standard of care antibiotic treatment. A lot of us, especially during the COVID pandemic, when there was a pause on FMT treatment at many institutions because we couldn't get pre-tested stool. We didn't know if we knew COVID was getting, shedding in stool. We didn't know if it was safe to do FMT. We were literally out of options for a period of time there, how to treat recurrent C. difficile infection. So this study is actually a research. It's a phase 2 double-blinded randomized placebo-controlled trial. It was multi-center trial sponsored by Finch Therapeutics, and they talk about the drug that they used was labeled as CP101. And basically, this medication, the CP101, delivered purified microbiome therapeutic community. And it was one pill orally taken, no need for bowel prep. And what they found, basically what they did after treatment, after identifying recurrent C. difficile infection population that met their criteria, they allowed first episode of recurrence of C. difficile infection if the patients were age 65 or older because of the high risk of recurrence in that patient population. Otherwise, the not under 65-year-old patients met the true definition of 2 or more recurrent C. difficile infection. And after they received the standard of care antibiotic treatment, they randomized 1-to-1 placebo and CP101, which is again microbiome orally delivered pill.
Or basically a capsule of good bugs, right?
Yes, capsule of good bugs.
Maybe I can't wait till they have good bug gummies or something.
Yes, we knew it was coming. But here it is. And what they found was 74.5% of their participants treated with CP101 achieved sustained clinical cure, which was defined as absence of C. difficile infection, which was statistically significant compared to placebo. In placebo group, 61.5% met, absence of CDI, and this translated into meaningful 33.8% relative risk reduction for C. difficile infection. No side effects, treatment-related side effects, none, 0 were reported, which I found extremely fascinating. And now this has gone to phase 3 trial, and I'm very excited to see. I can't wait when this is released because I think it will be. There was a huge need for this. I mean, imagine just taking one pill of microbiome, orally ingested pill, and you can have cure of CDI recurrence, absence of C. difficile infection. Yeah. And the data, by the way, showed that this pill basically increased the diversity of microbiome, and it also really led to colonization resistance. So it led to great gut microbiome recovery, so it can fight future infections. So it gives that resistance in the gut microbiome.
I love this study because I'm a huge fan ever since I found out over 10 years ago about FMT in that first abstract case report that we heard. Dr. Ali, you may remember that. But this has come so far, and especially in an age where we overuse antibiotics. And isn't that one of the risk factors is continued courses of antibiotics, which it strips away your good bacteria, and it can lead to something C. difficile, as well as other factors, especially in kids, right? We have kids and older people, and you can die from this. So the ability to, one of the things that was proven was the FMT, fecal microbiota transplantation, which is a little more invasive through a colonoscopy, but it's still very effective. There's evidence-based. Now you could take a little capsule, or hopefully once this goes through the trials, of the microbiome, good gut bugs, and repopulate a colony of great bacteria and eradicate that awful C. diff. So this is huge. It's amazing what's happening with the microbiome.
It really is. It really is. I mean, when we talk about cutting edge and like right at the cusp of huge innovation, I mean, imagine the implications once this,
Oh God.
Hopefully we will learn more from these trials and their sub-analysis. So
this is wonderful. Thank you.
I knew you really appreciate that.
You knew I'd be all excited about this. Oh my God, this is wonderful. Okay, so Pong, Dr. Ali, I know you got one more. We could just keep going on and on, but I know you guys got to get back to your patients, your families. Dr. Ali, you have the last volley here.
Okay, great. I think we will do ping pong some other time. So this is the session of ping pong today. Really went well. I think Dr. Singhal presented some really cool abstracts, and there were a lot. I mean, it was very difficult for us to select few, and I think we'll be happy to share in our next series some more interesting things that we learned in Vegas this year in our ACG 2021. So the last abstract that I selected to share with everyone today was another topic in inflammatory bowel disease that doesn't get discussed in the clinic, and that's the sexual dysfunction in IBD patients. And there are studies showing that sexual dysfunction is prevalent in patients, both in men and women suffering with inflammatory bowel disease. In the past, these studies have done some analysis of sexual dysfunction at a given point. We don't have longitudinal studies where they have actually looked at what happens with the disease, what happens with the treatment, and what happens to these sexual dysfunctions. So this study that was presented by NYU group looked at the longitudinal impact of sexual dysfunction on IBD and the impact of treatment on sexual dysfunction. Interesting study, 123 patients, so small study, but very interesting. Almost half patients were male, half were female. Average age was around 31. They did some very validated surveys for male sexual dysfunction scales and female sexual dysfunction scales, looking at different parameters of sexual dysfunction. And they did find out that there was a significant prevalence of sexual dysfunction. They did notice that the scores of sexual dysfunction correlated with the depression score. So the more you are depressed, the more sexual dysfunction was prevalent in that population. Same thing, they discovered that clinical disease activity also correlated with sexual dysfunction. More importantly, what they discovered that if these patients were on a therapy, that therapy to treat the disease also improves their sexual dysfunction. And that was another important thing that they discovered. And patients who were on therapy and they did not have a response to the therapy, they also didn't improve on their sexual dysfunction. So a very small study, but something that because of many barriers on both sides, we don't discuss these things. But I just wanted to highlight this abstract as one of my last abstracts tonight, that this is prevalent and reassuring that if you get a treatment and the treatment works for your disease, it will also help improve your sexual dysfunctions. So
I love that you brought that up. It's so, whatever the disease, it's always this biopsychosocial, it's the mind, gut, it always has a relationship, the disease, the flares. And I don't mean to keep bringing up episodes of podcasts, but I do this because I want patients to understand that they're not alone and that we've talked to many patients. We did a whole series related to sex and IBD and the different issues. And we had a wonderful woman, Kathleen, who was very open, so open about the struggles. And she had ostomy as well. And she was very candid. And it was interesting. We had a doctor on as well from Vanderbilt, and it is embarrassing. It's an embarrassing topic, but only if patients and providers let it be an embarrassing topic. And I think this study and why you've raised it is it brings it out into the open. It makes it's okay to talk about it, not to be embarrassed, and you're not alone. So patients, take heed of what Dr. Ali has brought here. And opened up the gateway to kind of have a discussion with your provider and not to be embarrassed. So I think this is wonderful. Both of you, Dr. Singhal, Dr. Ali, I can't thank you enough for coming here and talking about abstracts. I am such a science medical geek, and I could talk about abstracts all day long.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.